HCHB is proud to sponsor the Last Visit First podcast, which explores the complex issues faced by today's home health and hospice providers.
In the spotlight today, Chief Revenue Officer Hannah Pearson, explaining how HCHB uses technology to connect people.
One of my favorite phrases is relationship architect. The focus is about the client and building the right community, the right fabric of community around our customers, making sure that from the very bottom to the very top, they had a resource and a contact to reach out to with any problems, and that we could connect them quickly and expeditiously to the right resource. That's where the client success team was born, and we touch people at every level of the organization.
Welcome to the Last Visit First podcast. I'm super excited to be joined today by a really dear friend of mine, Tracy Dent. Tracy's the Senior Vice President of Clinical Operations at AccentCare. She comes with more than 20 years of clinical leadership at AccentCare. She's a mom. She might be one of the proudest Gigi's I've ever met. So I've heard so many stories about her grandkids and looking forward to hearing those. She's a devoted friend, and she's a really good golfer as well. She's also the first nurse that we've had on the Last Visit First. So we kind of saved the first nurse to make Tracy feel special. And happy to see you, and thank you for joining us today, Tracy.
Absolutely. Good morning, Tom.
So let's talk about, where did we first meet, Tracy? I was thinking about it last night as I was preparing. When was the first time we met? Do you remember?
Texas. Probably. I mean, it was the IntegraCare Encompass days,
I think
right?
so.
It's been a minute.
Yeah, I think it was back in 2006. I went back and looked. That's when IntegraCare was first looking at home care home base, and you were in the room, and I came in, and I remember it was one of the hardest demos I ever did because I was getting drilled and do this, do that, do this, do that. Show me this, show me that. It was pretty wild.
Well, you made the mistake of asking me what I wanted. When you asked me what I want, that was your fault.
It's my fault for sure. And I think we had most of it, but not everything. But we built a lot of stuff together. I appreciate you always pushing me. I know that was something that you still do today, and all the companies that we're partnered with here. I still get pushed by Tracy, but she's also the very first person I'll make a phone call to when I have a question or like an idea, and I'll be like, "Hey, what do you think about this?" She's like, "It's stupid, Tom." Been told that more than I've been told. Hey, that's a cool idea.
But listen, when you have a cool idea, it's a really cool idea. So take that as a win.
That's right. That's good. Thank you. Tell us your story. Walk us through. When did you become a nurse? How did you get into home health and hospice? Tell us the story.
Okay. Went to nursing school young, right? Got out, thought I was going to do something really important and save the world. But my husband, Mark, as you know, is a flight nurse. And back then, the medical crews in EMS were not regulated in any way. So although the pilots had caps on how many hours they could work, the med crews did not. That has since changed. Let me calm everybody's fears. But Mark worked a ton, right? We had 4 kids. And so it became really evident early on that I was going to need to do something that allowed me to practice nursing, but also take care of 4 babies. So I decided to give home health a try. A friend of mine said, "Hey, you might really like this." And I said, "Okay, I'm going to go do that until our youngest is in kindergarten. And then I'm going to go back and do something important," right? I really thought I would end up being like a transplant coordinator. I really had a passion for ESRD patients. And so I thought that's what I would do. And then I got the bug. Pretty early on. I'll give Marilyn Bowen and Tiani Aurelio probably credit for that. But when I saw how impactful home care could be, both in rehabilitation and also end of life, there was no doubt this is where I was meant to be. And that youngest, who I was waiting for to go to kindergarten, is 27 tomorrow. So here we are. I'm still here.
Well, happy birthday. It's hard to believe 27 years ago you had your youngest baby. So, yeah, happy birthday. Talk to me about, so you're at IntegraCare, Tiani, and then you moved through your career there. You started out as a nurse in the field, and then when did you start taking these back office, promotion, manager, boss roles? Tell me about that. How did that happen?
It didn't really take long, I think, and we still do this today in the industry, right? We take good case managers and we say, why don't you come in the branch and learn this side of it. And that's exactly how it happened for me. And I always joke, I joke with Chris and Jason that they let me run a branch long before they should have. But luckily I had great people around me who taught me all the things. But I look back now and think I would never have put me in charge of that branch. So yeah, I grew up in this industry.
Yeah, it's amazing if you look at the number of people that were successful through the IntegraCare, startup essentially that Chris and Jason and you and Tioni did. And now you go look at all those people. I think all of them are still working, leading companies or, high chief jobs. And with the exception of Tioni, I think she finally retired and went to the beach last I heard.
She's playing golf every day, living her best life. And occasionally I'll call her and go, okay, talk me off a ledge. And she's always good to do that.
Yeah, she's always been a true fan of yours too. That's awesome. Tell us a little bit about AccentCare. So how big are you guys? Where are you? What are you doing? And then your role inside AccentCare.
So I came to AccentCare. Actually, I go back to Jason. Jason Gerard was at AccentCare and a part of the organization, and they were developing a role. Actually, at the time, they didn't even know what they were going to call it. It ended up being director of clinical operations, and it was a smoke jumper. I mean, let's just call it what it was, right? And so I came in and I met with Sarah Castillo, who was the chief nursing officer at the time, and Dave Davis, who was the VP of clinical operations. And they said, listen, here's what we need. And we think you have the skill set to do that. And it seemed super interesting to me. And mainly because as somebody who had been in leadership for a long time, it had no direct reports. I didn't have to be the payroll girl. I didn't have to be the HR girl. Yeah. And I thought, that's a nice break for a minute. Let's do that. And it grew, right? As our organization grew. And the thing that I love about AccentCare is it really has grown through acquisition of great mid-level size organizations that we bring into the family. And I always love that sort of process because I learn something new every single time. And I'm like, oh, why didn't I think to do it that way? And so we are a blend of best practices from across the country. We also do a lot of partnerships with large hospital systems, which I also find I learn a ton from, how they manage population health and community health from those aspects is always interesting. So that's sort of how we got to where we are, where we're fairly large home health operation. And I get to work with some of the most amazing clinicians I've ever had the privilege to know. So yeah, it's a good place to be today.
And you guys are you do home health, home care, and hospice care, correct? All three service lines?
Yeah. And we actually have a fourth, awesome. Palliative care. So yeah, and we have a broad spectrum in our continuum. We try to sort of fill those gaps when we identify them. And our Texas PCS business is just slightly different than what we do in New York because New York has different regs, and Joanna and that team do a great job there. So I got exposed to a lot at AccentCare that I had not seen before. So I feel like I learned something new every day.
That's awesome. That's good. I'm glad you're still learning. Although I'm shocked in all these years you still learn, but I think the government helps us a ton by changing the regs every few years, and it keeps us honest. It's like software. Every 2 years you got to learn something new. So yes. It's pretty wild. All right. Speaking of the government, Tracy, we got a little bit of a rate cut proposal out there. Yeah. Probably going to be on Halloween or somewhere really close to Halloween. They're going to ruin our day and give us a whole bunch of stuff to read. Your thoughts, one, on that, and two, if it is a true 6+% rate cut, what are we going to do? How do we mitigate it?
Had a little chest pain when you said that out loud. Listen,
sorry.
For 20 years, they've been ruining 2 holidays for us, right? They like to send me the proposed roll on July 4th, which, as you know, is my favorite holiday. And then they send me the final roll on Halloween. So thanks, CMS. Here's the thing. We have over the years had to learn to pivot. For my friends that watch Friends, we have to pivot. This will be no exception. I'm hopeful. I'm optimistically hopeful that the industry leaders who have spent a lot of time um, explaining what we do for a living to the folks in DC, that it's not going to be at that 6%. But regardless, wherever it is, once again, we will have to learn to do more with less. And I think most of us who've been in the industry for a long time have learned to manage through that. The piece that is most concerning to me this go around is the impact of access to care in rural America, and it has the potential to be really, really impactful this time. And for those that may be not as familiar with our industry, in rural America, there are oftentimes one home care provider, either home health or hospice, in a county. And oftentimes those are not organizations that have a national presence. And so when there is a rate cut that is this impactful, and their margins are so slim as it is, they may not be able to sustain. And that will be incredibly, incredibly impactful to patients who need access to care.
Yeah, it's pretty amazing in the industry how much, I mean, we're seeing more volume coming in. We're seeing way more volume that we can't take too because of rates, payers, in network, out of network. It's becoming a real challenge. And I think, by Medicare continuing to cut and cut and cut, you're going to see either more consolidation because people can't afford to do all the back office things and go see the patients, or you're going to see, people going out of business. I mean, we're already starting to see people are giving up. They're like, it's just too hard now. It's not as profitable as it used to be. It's too hard and it's not worth my time to do it, which is really sad. I agree with you.
My greatest wish is that we could get the legislative folks who make the decisions and the payers who fund a large portion of this these days to understand that this venue is the lowest cost of care with the best outcomes. Why would you not want your patients to be here? So I say that as often as I can to anyone who will listen.
It's true. It's true. Nana wants to be home with her remote control, her bed, her comforter, her blanket, her dishes, her family, her pets. She didn't want to be in a hospital. Nobody wants to be in a hospital. Talk to us about that. This is called the Last Visit First podcast. Talk to us about that one patient that that you remember, that one that sticks in your mind always.
Yeah, I will go back to my days in the field as an LVN. So we're going way, way back. I come from a very large family. Tom knows this, but my dad has 8 brothers and sisters. So I didn't understand, that everyone didn't live that way. And one of the very first patients that I saw as an LVN, now, for those of you that have been in Texas for any amount of time, this was a CBA waiver patient, right? So I saw her a lot. She was mid 80s when I first started to take care of her, and she was fairly healthy at the time. But then, all of her comorbids sort of started percolating, and I started to see a pretty significant decline in her. And when I say she had no one, she had no one. She had never been married. She had never had children. She was an only child. There were no nieces and nephews, cousins. She had no one. And when I mentioned earlier that I sort of got the bug, I think she was definitely the one that gave it to me, because I thought, who advocates for her if we aren't here? And she ended up going on to hospice, and we got her into an great assisted living, and her end of life experience was exactly what I would have hoped for her. But what if we hadn't been there? And she sticks with me for sure. Yep. And I think last visit first is this going to be the last interaction that I have with her? Is this what she's taking with her? And did I give her the best of myself at this visit? That's what it means for me.
That's awesome. That's really cool. We thank you for sharing that. I have a similar story that I haven't told, but I'm going to tell now. When I was in corpsman school, so we had to do a rotation through the VA hospital in Great Lakes, Illinois. So I went through boot camp and then went to corps school, and we had this one patient that had been there at the VA, essentially a nursing home for 10 years. She was an old World War II vet, and he was a really cool guy, and he was in pretty good health, had some dementia, but he never talked. And so I would go in, we had to do nail care and shave him and, get him up and dressed and all that stuff, make him go walk and all those kind of things. And I'd tell stories to him and just talk to him like a normal human, but he never responded to me. I mean, he would do facial expressions and stuff like that, but he would never talk. And so I took care of him for 2 weeks. It was part of our rotation. And my last day, he said, "Doc, really appreciate you. Thank you." And I'm like, holy shit, did that guy just talk? Like, it floored me. So I ran out and got the nurses at the nursing station. I'm like, "Hey, this guy just talked to me." And they were like, "No, he didn't." And I'm like, "Yes, he did. He just said that." And so they walked in with me and he was talking. And I'm like, "Why don't you talk more?" And he's like, "I have nothing to say." It's like, "I'm just enjoying my life. And thank you for taking care of me." This blew my mind. I mean, but he was the one that kind of got me and said, "Okay, I'm gonna stay in this healthcare business. We can make a difference."
We can. Yeah. I love that story.
Yeah, it freaked me out. I'm like, "Really? But take care of you 2 weeks. You never said a word."
Yeah. That World War II generation, they're just built different.
Yeah, for sure. It was, it's, yeah. And I think you have a story. You were telling me about a book, or you actually sent me a book, and I've already started reading it. So
Yeah.
tell me the story about how you met that World War II vet the other day.
Yeah. So Mark and I on vacation, as all of you I'm sure can appreciate, we had flight delays. And so we ended up very randomly spending an overnight in Boston. And because I've been traveling for years, I booked the closest Marriott property to the airport, right? I wanted to go sleep and get back. We had to be there at like 4 the next morning. And the hotel had a restaurant. So that was great. And we walked downstairs and we just happened to run into a gentleman and his son. And he's the last living member of the 82nd Airborne from World War II. His name is Gene Metcalf. He's 103. And when I tell you, I spent 2 weeks in Greece, right? But meeting him was the highlight of that trip for me. He told us all about it. He had just come back from Holland, where they had went and visited the actual site that he paratrooped into 82-ish years ago. It was amazing. Yeah. And there is a great book written about him. And I encourage everyone to read that story. But, he's why we do this.
Yeah, I'll have Cole put a link to the show notes in there to that book on Amazon.
Yeah. It was absolutely amazing and the highlight of the trip for me, for sure.
It's so cool. Crazy that you flew all the way to Greece. You saw all the ancient ruins and all that, and you come back to America and you sit down next to one of the coolest people you've probably ever met. And that's the highlight of you. I also tell a story that I met a Medal of Honor recipient one time at a golf tournament, and I was the president of this trophy club golf thing. And so they said, "Hey, he wants to have breakfast. Will you have breakfast with him?" And I've met with all kinds of people in my life. I've been very blessed to meet some real, stars, George Strait, people like that. I was so nervous meeting this guy because he was a Medal of Honor recipient, and one of he didn't want it. He wasn't proud of it, none of that stuff. But he was using the his situation to share the message about the military and how we should take care of them. And it was really cool. But I literally couldn't eat breakfast. My hands were sweating so bad. I mean, I'm sure I was just shaking all over. I was so nervous. Yeah, it was really neat though. There's a few people in the world that do that. Let's switch over to workforce and culture. So, and recruiting, retaining, retention, nurses, social workers, chaplains, aides, volunteers. I mean, how do we do it? What are your strengths? I mean, I think you have an amazing following at AccentCare, and I know I've been very blessed to know a lot of the people that work for you that love working for you. So, I mean, how do you do it? Like, how do we keep these people? How do we make them happy? How do we give them what they need and also keep them productive?
Yeah. So I'll start by talking about my direct team. I think the ladies and gentlemen that work directly for me, and I'll go back when I started as a DCO with no direct reports. Now as the SVP, I'm 218. So I think Sarah kind of did a bait and switch on me a little bit, but here we are. I learned a long time ago from a great leader who I will not give credit to on this podcast, that if you surround yourself with people who are smarter than you and stay out of their way, you'll be successful. Chris Gerard taught me that, by the way, but I hate to, make him seem smarter than he is. And I have really followed that, my direct reports, a lot of them were at IntegraCare. I just have great people, and in turn, they have great people, right? I think this battle that we get into currently is with field staff specifically. I'm going to talk about that for a second. With field staff specifically, they can go down the street or to the next town over and make $3 more than what you're going to pay them. And some of them are going to do that, right? But I think the way you keep really good people is not by giving them another $3. It's by making them feel like you are invested in them as a person, as a professional, that you want them to grow, that you're asking them, what do you want to be when you grow up? Where do you want to be in 3 years? And here's how I'm going to help you get there. People leave bosses. They don't leave leaders. So if you can cultivate leaders, that's the key, right? Because people aren't going to leave someone who's really invested in them for an extra $2 down the road, right? And if they do, they're probably not the person you wanted on your team to begin with. So I think that's, as an industry, we have to start cultivating leaders of leaders in order to have a sustainable workforce.
Yeah, it's interesting. I was having a conversation with a previous podcast guest, and one of the thing, if you're the best salesperson on the team and you're hitting your quota constantly, we make you a sales leader, but there's no training in there, right? All you know is what the guy before you or the guy after you that you liked or didn't like did. And same thing with nurses. When you're the best nurse out there, you're hitting productivity, now we make you a nurse manager. And then you've never had coaching on, how to deal with someone in a crisis situation. I mean, hopefully you had some of that as a nurse, but for the most part, how do I get people to hit productivity? How do I, how do we change? How do we go from IPS, PPS to PDGM to, OASIS, ABCDEFG, it's a lot of change that goes through it. And so I think, developing leaders as you go through that and spending time with them and making sure that they understand the why behind what we're doing is super important as well.
Yeah.
All right, let's jump to technology. AI. It's all we're talking about. Everybody's talking about AI. Give me your opinion on it. What scares you about it? What excites you about it? What do you think? What do you think we should be living in the AI world? Is it ambient listening, or what is it?
Ambient listening for sure. I mean, anything that's going to make life easier for my bedside clinicians, I'm all about it. I do think that there are great use cases for AI that are being both developed and in play right now in our industry. I think what scares me is that we have to sort of keep this mindset that systems make recommendations and people make decisions, because there's always going to be a piece of this that the computer can't possibly know, right? And so retaining that human aspect of assessment, I think as long as we're very careful that we don't get so far away from that we forget how to do it, I think the possibilities are endless.
For sure. What scares you about it?
I think what scares me is just that people will start to say, well, the system said I have to do this.
The interesting thing on wound care and some of that kind of stuff, I mean, a robot can't do wound care. I mean, they'll never be able to compassion around that. And, they're saying that, they can do the basic chores and computer kind of things, which is great. If we can use AI to document better, stay more compliant, make sure we catch everything. I was telling a story yesterday about, why is it so hard? Why do I got to use a buddy code inside of our EMR to figure out when I need a PTI and R? Why can't some systems say, hey, it's been 2 weeks since you did a PTI and R. This patient's on Coumadin. Get a PTI and R. It should be that simple. But instead, we're having to put in, humans are going to have to remind. So those are the kind of things, how do I make documentation summaries easier? How do I read 200 pages and tell you the most important things out of there? How do I pull medications out of a picture? Those kind of things, AI makes life easier for a clinician. And we can spend more time with Nana. We can do ambient listening. There's, all this controversy around ambient listening, but me looking at you and, checking your ears, eyes, nose, throat, doing a full physical exam, I can talk to that and the system can recognize that, hey, you do have a wound on your, left shoulder. You do have, here's what it looks like. Here's what it does. And just by describing it, I can do my documentation versus having to sit there and type it in at, 7:00 at night while I'm supposed to be watching Monday Night Football.
Yeah, you know how I love pajama charting, right? I want to rid the world of pajama charting. I think the other thing that we have to like think about is the million nurse shortage is real. Make no mistake, right? And those applying and graduating from clinical programs, whether it's nursing or therapy, are getting less and less every year, right? On the flip side of that, there are more sort of Medicare age eligible patients coming in that are going to need care. So how do we, again, do more with less? And how can we use technology to help us lay hands on a patient more routinely when we have fewer clinicians to go knock on the door?
It's true. It's true. And is there other types of technologies out there that you like? I mean, like telehealth, those kind of things. I mean, where does that play in home care and hospice and home health?
I think probably more so in home health than hospice. I think I'm a huge fan of telehealth. Really, really hoping that the final rule plays in our favor there. Um, a lot of these patients who need access to care and are homebound, as is required by the regulation, can't drive an hour to be seen, by a primary care physician that's in network. So we have to figure out how to bridge the gap and get these patients the care that they need, whether it's from my clinicians, the physician, a therapist, behavioral health patients. We have got to figure out a way to deliver care in the home with the limited resources that we have.
Yeah. I know we've been fighting this for years with CMS, trying to get telehealth, at least covered, even at a discounted rate. I mean, just give us something for it. We're all doing it. We're all checking on patients. We're doing that. And I think there's telemonitoring and then there's telehealth. Telemonitoring would be more like an ambient device in the home or a scale and a blood pressure cuff and all that. And there's value there, but it's less valuable in telehealth, which is me on the phone, just like we're doing right now, doing a virtual visit. And, there's privacy and security and all that stuff around it now with passwords. So why can't we? I don't go to the doctor. I mean, when I do call the physician for whatever reason, we do a virtual visit. I haven't been to his office in a long time. I mean, other than going and getting labs done, I know how to take my own blood pressure and there's machines that do that. So he likes to put his eyes on it, every now and then, but for the most part, you don't need it. So why not? And so I don't understand why CMS is not opening the door for that. Even if they pay us a discounted rate, it's at least something for it.
They make it available to able-bodied humans, but to our most vulnerable population, it's not available, which I just can't. I can't make that math for me.
That's right.
So
that's right. It's especially now everybody has technology. I mean, everybody has a cell phone now. It's for the most part, and so why not make it available? All right, switching over to quality and outcomes. You guys at AccentCare, this is the part that you spend most of your time on. What are you doing? What are you worried about? What are you looking at constantly around quality outcomes? I know hospitalization, ER visits, and VBID, and all that stuff. But what's Tracy the best at, and what keeps you up at night?
Yeah, I think this goes back to surround yourself with people who are smarter than you. Because Maggie Suggs, who leads our quality team for home health, and Donna Hyatt for hospice, and then we have Irene Cole, who is the industry leading subject matter expert for hospitalizations. And I think what we have discovered is that you cannot manage outcomes retrospectively and get anywhere, right? So we take a very proactive approach, regardless of what, if we're talking about, last days of life in hospice or transfer and ambulation in home health, whichever the metric is, we need to understand that the clinicians who are making those assessments and decisions understand not only the CMS guidance, but also how an episode, I'll say in home health, an episode should play out and what is a reasonable expectation to get that patient to, and then make sure that we're building and developing a plan of care that lets us get to that outcome. Maggie has a phenomenal team of people who work directly with not only our back office, but also our field staff, right? Because if all my back office is doing is constantly going back and forth with the field staff to correct things, that's also not the most efficient way to get this done. And so I think that's the differing approach that we've taken, is that we get down to the single point of contact at the bedside and make sure that everyone understands how do we get to the outcome we need to get to for this patient. And it is a very patient-centered approach to quality. So I like to believe that that's why we have been as successful as we have. We also know that with potentially preventable hospitalizations coming into play in the industry this year, that the patients who were, most likely to end up on our list in 30 and 60 day are not at all the same patients that are liable to end up on the PPH list, because the metric is vastly different. And so I think all of us, right, are still working through how to wrap our heads around how to manage the KPI. But at the end of the day, if we're taking really good care of patients every single day, the rest of it will work itself out, whether it's quality or finance or whatever. Do the best we can for every patient today, and the rest will work itself out.
Yeah, it's awesome. That's a great way to say that. You and I had a long conversation. I don't know, it's been 6 months ago on our monthly call and we were talking about the length of stay for home health patients in the rural communities, and how, because there's no other access to no other care other than home health, these patients are on service for a lot longer. And so our rehospitalization metrics are a lot worse, because we're keeping a patient for 3 or 4 episodes of care, and they have more of a chance to go back in the hospital versus someone that, does a 30-day, one benefit period and then, or one billing period, and then discharges the patient. And that patient still goes back in the hospital, but because they're on service with us for a lot longer, our hospitalization scores or rehospitalization scores look worse. Thoughts around that? Any more things you want to explain around that? But I thought it was really interesting, because as we were really diving deep into it.
I think we're still in the infancy of understanding what the impact of length of stay will be on that metric. And we've talked a lot about rural healthcare today, because you and I grew up in rural healthcare, right? I think that's important for people to know. Like, we lived in the middle of nowhere, West Texas, where it's an hour drive to the closest hospital, and you have one ambulance for the whole county. Like, that's the reality that people live in. When you're in a metro market,
Sure.
your options are far different. And so this particular metric has the potential to be very impactful to rural America if we don't get it right. But I'm pretty committed, as are several of my friends who are at other organizations, to ensuring that we understand the impact, but also that we continue to do what's right for the patients.
All right. That was awesome. Thank you. Talk about the future of care. So shake your crystal ball 3 years from now. What is home care? What is home health? What does hospice look like?
I'm hoping in 3 years from now, this is the first choice as a site of care instead of the last. I might be hoping for too much, but that's what I'm hopeful for. I don't believe that patients are better served in most instances in a facility setting. Now, there are patients who have no business being at home, and we talk about those every day in this organization. But we have to, first of all, get regulation and legislation that allows us to deliver care in the home. We have to have onboarding and training and protocols for the field staff that allow them to feel comfortable delivering a higher level of care in the home. I think we're all headed in that direction. You hear a lot of people talking about hospital at home and all of these various sort of projects that are going on to try to figure out how to do that. But we can't get there if we don't have the funding to support it. So I think that's step one.
It's great, and it's amazing. I'm really excited about continuing to advance the hospital at home, or 24-hour care, or those kind of things. I think it's way cheaper. It's the most desired. It's what Nana wants. So how do we figure that out? And if we don't, we're going to run out of money, and we're going to run out of Medicare dollars and not be able to figure this out. It's super interesting. Like, I live in Minnesota in the summertime, and there's an ALF on every corner. I mean, I know you guys are big with that. In Minnesota too, and AccentCare did a big joint venture up there. There's literally assisted living on every corner. I mean, it's amazing how many people in Minnesota are dual eligibles and live in assisted living. But I mean, that's their home, but they're also, I think they do a pretty good job of caring for those patients in those facilities, but it's expensive. And by the way, it's self-funded. You have to pay for it yourself for the most part. And so that's where it gets really expensive. And if you didn't save your money at the end of life, or you weren't blessed enough to have enough money to do that, then what happens? Then you end up in a facility that's less desirable. So I'm worried about that. I am. What? How much time do you spend in hospice and transitioning patients from home health to hospice? That's a big program. I know you guys work on there at AccentCare and throughout your career.
Yeah, my partner on the hospice side, Charlotte Mather, who's one of the most phenomenal clinicians I've ever known, and she and I talk often about how do we get patients at the right level of care at the right time? How do we have the right kinds of conversations? How do we identify people who don't need to be having the conversation, right? I think that's almost just as important as who does need to have it. Home health clinicians are not always comfortable having these conversations. So why do we keep asking them to, right? So we have a transition of care team led by my colleague, Michael Borsellino, who does a great job. But we took the approach of we're not just looking at home health to hospice, because that play can sometimes feel a little, right? We took the approach that here's our continuum. Here's everything we can offer to a patient. What does this patient need right now in this moment? And sometimes it's palliative, and sometimes it's PCS, and sometimes the PCS patient needs home health. And so it really is about care navigation in our organization and not necessarily just getting patients from home health to hospice. We want to make sure they're getting everything they need at the right time. But I will also say that we have done a lot of education and training to give people confidence to have the conversation if it's the right thing to do for their patient. We're partnering our home health and hospice staff to go in together to have those conversations, because patients shouldn't die on home health, right? And I say that often because not only is the home health group clinicians, they're rehab focused. That's what drives them, right? And so when it's about end of life, we need to hand that over to a clinician who is really good at end of life. And also, by the way, it's as important to the family as it is the patient, because when we don't get them to hospice and they don't have that great end of life experience, it can be very traumatic, but also they don't get the benefit of all of the bereavement activity that comes along after the patient has passed, which can be just as important as what we do at the bedside in the final hours. So that's sort of the approach that we're taking.
That's awesome. It's super interesting. I know you and I've had a conversation around these ESRD patients, so end-stage renal disease, and I've looked at thousands and thousands and thousands of patients that are really sick, that are, most of them have multiple comorbidities. They have CHF, they have diabetes, they have, COPD, something like that. But because they're on end-stage renal, or they have end-stage renal disease and they're on dialysis, that no doctor's going to tell them to stop dialysis. So they never move to hospice. And these patients, some of the worst, most sick patients I've ever seen, which should have been on hospice, that qualified for pretty much every LCD, are not on hospice. And you're like, why are we not getting this patient on hospice? Because the doctor won't tell them to stop dialysis. If I stop your dialysis, you're going to swell up and die, and of all that poison in your body. But why the government won't pay for dialysis and hospice at the same time baffles me, because it's the worst patients that I see are sick, and need to be on hospice and never get there. Thoughts? How do we fix that? I know there's a bunch of lobbying efforts around it, but how do we solve this in the industry?
Yeah, I think to your point, there's a ton of lobbying going on around this. I could not agree more. And I also have a personal passion for these patients, because before I was even a nurse at 18, also, who hired me to do this? I was a dialysis technician in a unit, and I became a certified technician. And by the way, I tell this story all the time. My CHT exam, the certified hemodialysis technician exam, was 10 times harder than my nursing boards. So kudos to anybody listening who has taken that test or is actively getting ready to take that test. So hard. But these patients are the sickest of the sick. They need to be able to receive care. I'm going to go back to what I said before, is in order to get to where we need to be in delivering the highest possible level of care in the home, the legislation has to support us to do it. And right now we just don't have that with this really fragile group of patients. And so I'm hopeful that changes. I'm hopeful the lobbyists make headway to make, people understand that they shouldn't have to withdraw from dialysis in order to get end of life care if that's what they choose to do.
Yeah, it's pretty scary. It's the one that really bugs me. That one, and the other one that I'm spending a lot of time on is behavioral health. And just, if Nana's sad, lonely, scared, she's an alcoholic, she's got alcoholism, she's drug addiction, whatever it is, we should keep her on home health. We should absolutely take care of her. But because of the homebound status, do you really want somebody that's depressed, scared, lonely to be stuck in their home? They can never leave their home. They're there alone by themselves. But in order for us to care for them, they have to be homebound under the current administration's guidelines. And so how do we solve that? How do we, I know we've been fighting this since I've been in this business, redefining what homebound means, and that's since 2005. But how do we fix this? How do we convince CMS that the homebound status is causing them to spend a lot more money?
I think we have to be able to, we're going to have to take some risk to get the data to support the argument, even though we all know it to be true. My colleague Dave Davis, who and he was a phenomenal clinician and a phenomenal human being. He's passed on, but he was very, very passionate about behavioral health. He developed the program at AccentCare and really stewarded it under his leadership for all those reasons. Right? These are, again, some of the most vulnerable. And we actually had a conversation several weeks ago. People laugh at me because you're not allowed to use the word non-compliant at AccentCare. It's not in our vocabulary because time and time again, I saw that word being used with this subset of patients. And I'm like, yeah, that's a cop-out. You're being lazy. Because there's a reason that patient is not actively participating in their care. Go figure out what it is. Right? So no one is allowed to say that word around here. And oftentimes the leading cause of that is depression, anxiety. It might even be a financial restriction because of their behavioral health disorder. They're not great at managing funds. And the list goes on and on and on, but don't be lazy. Go figure out what's actually happening and get a solution in there. And I think we just have to keep doing that until people understand that. I would venture to say half of all hospitalizations are rooted in untreated depression and anxiety. It's what drives med error. It's what drives non-adherence. It's, it also, to your point, they self-medicate with things they shouldn't be. And so it's just this vicious cycle. But we have to get people who can help us to hear that and to understand it in order to fix it.
Yeah, it's pretty. It's an area that I'm spending a lot of time on. We should be able to predict it. We should be able to identify it. We should be able to come up with better treatment plans for it. But you got to figure out how to. Is it the right thing for Nana to be homebound? And one of the reasons that they get to go on hospice, you don't have to be homebound to be on hospice, but the home health benefit requires you to be homebound. And these patients need our care. We should be establishing behavioral health protocols. Again, they're not going to get in their car and drive to a hospital. They're not going to go to the ER unless they need refills on their meds or something. But we should be able to figure out protocols to get these people up, active, and out of bed and just laying there. Other thoughts? Anything else on your mind that's keeping you up at night, Tracy, as we're going into 2026 here pretty quickly?
I think right now the final rule is keeping me awake. I think the shutdown is keeping me awake. I think some of these really important waivers from 2019 not getting extended, not getting written into the final rule keeps me awake because we have fundamentally changed the way that we care for patients with these waivers in place. And if they were to go away, I don't know the impact on our workforce. I don't know the impact on our patient population. I think that's probably the thing that's keeping me awake right now. But I think if I look into 2026, it's how do we recruit and retain and educate the best of the best to be in this space? You and I always joke that years ago that there was this, and maybe still true to this day, that, home health and hospice is where nurses went to die, right? It's like when you couldn't do a 12-hour shift anymore, you can go do that. And that is so far from the truth. These clinicians have to be a jack of all trades. They have to know how to do everything without a team down the hall, right? And in the hospital, it's become, and for all the right reasons, right? It's become very segmented, and you have a team for this and a team for that and a team for this. And when you come here, it's you. It's you in that home. And you have to know how to start an IV and draw blood and do wound care and do a comprehensive assessment that actually leads to a plan of care that means something for that patient. And so and maybe I'm biased, but I think this is where the best of the best clinicians should come to live, right? Because you need to have that level of skill and passion, so that we can continue to do this correctly. So that's where my mind goes, is how do I convince those little tiny shooting stars coming out of school, nursing and therapy school, that, this is where they need to be.
It's pretty interesting. And I think the flexibility that home health and hospice, all agencies are trying to do, and I know your team does a great job of this, but the flexibility is what most nurses want. Most nurses are coming out of school, they're having families, they're either they're doing lots of things in their lives, and so this side of the industry allows a lot of flexibility. I don't have to start a shift at 8:00 and end it 12 hours later. We allow the flexibility. We allow you to be in your car. You allow you those kind of things. But the challenge is you're absolutely right. You got to be a pharmacist. You got to be a wound care expert. You got to be a respiratory therapist. You got to almost be med reconciliation. You got to be an aide. I mean, you got to help with ADLs. You're doing a lot of stuff that you wouldn't do in the hospital that you would call somebody else to do. And so, but you also have the complete flexibility. And I had April Anthony on the podcast a couple of weeks ago, and she was talking about, it's everybody is somebody's grandparent or mom or dad or family member. And it's amazing what we get to do. And we get to spend a lot of time with these patients. And we're in ICU or in the ER. When I was in the ER, as soon as the shift was over, you never saw that patient again, ever. You just wonder, I wonder what happened to him, but you never saw him again. In our world, we're spending months and months and months with these patients. So I agree with you. I think we got to figure out how to convince everybody that this is the right place to come work, and we allow the flexibility and become the agency that people want to work at. That's it's one of my mottos is, how do I be the place you want to work for, not the place you have to work for. All right, yes. Tracy, last question, and then you can ask me any question you want. Okay. What's your legacy? What do you want your legacy to be in 5 to 25 years when you retire from now? And people talk about you, and like we talk about Tioni, we talk about, Sarah, we talk about those people. What do you want your legacy to be? What do you want people to remember you as? And not just Gigi.
That was a good Gigi. I think what I want people, if people say about me in 25 years that she left this space better than she found it, I think that's all I can ask for. And I hope that people will say that.
It's pretty awesome. Yeah. I think you have. I mean, you've grown up in this space. Unbelievable. From beginning to boss. I mean, it's pretty cool.
Yeah.
You ever want to go just back and be a nurse in the field and go see patients again?
Okay. Yes, I do actually. And I'm going to end with this story. So my dear friend, her mom is sick, and we're sort of working through, that. And she ended up back in the hospital for a symptom that I missed. I missed it. Which you can imagine, me, what that did to me. And so I called my RDO in the Austin area, Tanya Hopper, who's also an IntegraCare girl, right? For any of my IntegraCare folks out there, if y'all want to come hang out over here with us, call me. But I called Tanya and I said, Tanya, I need to go see patients. And she said, I need you to say more words. I said, listen, I feel like I need to go lay hands on some patients. Like, am I getting that far removed that I'm missing stuff? And she goes, okay, well, no, you can go shadow some clinicians and you can go, talk to some patients, but you're not getting in my charts. And I thought, okay, that's fair. That's fair. So yeah, I mean, I think for sure I don't ever want to get so far removed from the field that I don't know how to help them. But also in reality, I know no one's ever hiring me to do that again. So there you have it. Maybe April might like.
No, I don't think so. they're gonna use your skills everywhere else. But yeah, it's fun when you, as a PA, I haven't seen patients in years and years and years, but I always want to go back and see patients. I
Yeah.
always remember like what your husband does as a flight nurse. I used to ride around on the helicopters as a paramedic, and I love that. It was, the adrenaline was unbelievable. It was fun. It was great and all that. But that we all moved on to different jobs, and now there's different skills that we need to do.
Yeah.
Tracy, thank you so much for coming on. It's a real
Of
pleasure to have you.
course.
You've been a dear
Yeah.
friend and advocate, and I'm super excited to have you here. And thank you for all your stories that you told. And I think the listeners out there will absolutely learn from Tracy Dent.
Well, listen, I hope so. Thanks for having me. I feel honored to be the first nurse, and I'm hoping we can come back in January and talk about how the final rule had everything we dreamed of.
Now it must be Christmas. Holy cow. Yeah. I just relax a little bit, government. Come on. I look at it every year and I'm like, holy cow, we've just been cut on whole mouth. So hopefully this year they relax. And, I got faith in Dr. Oz and faith in Secretary Kennedy, and hopefully that they understand this and they see it. They've been around healthcare for a long time. So hopefully. Thank you so much, Tracy.
Bye.
Hello, I'm Jennifer Maxwell, co-founder and CEO of Maxwell Tech. Here at Maxwell Tech, we believe that no family should ever feel forgotten after that last visit. Too often, grief leaves families feeling isolated. That's why we here at Maxwell Tech created Nana Connect Bereave, a simple yet powerful way for care organizations to extend compassion beyond the bedside. Bereave really does deliver timely, personalized messages that bring comfort and connection when families need it most. Our largest hospice partners are sending out over 10,000 messages a month. That means that over 19,000 family members are being connected to their care teams in meaningful ways. And the results are extraordinary. Engagement scores are running between 30 and 40%. Families love being supported in this manner, and the results are seen in their engagement. Bereave is already touching millions of lives today, and we are just getting started. If your organization is ready to bring humanity and healing into bereavement care at this scale, please visit us at maxwelltech.com.
Hey, this is Alex with Steno Health. Our mission at Steno is simple: to improve the quality of life of the post-acute care clinician. Steno uses ethical, compliant AI to capture visits in real time and turn natural conversations into accurate notes and forms. We are clinicians ourselves, and we've designed Steno to never feel like an extra click or an extra burden in your day. The goal isn't to replace anything, but to support you in every aspect of your day so you can spend more time with your patients and still have the energy and freedom to be present with your family at the end of the day.